Hey everyone, I hope you're all doing really well. Welcome back to Karan Academy. My name's Karan, and today we're going to be talking about gout and pseudogout. So, starting off, what is gout? Gout is the deposition of uric acid crystals into the joints, and it presents with acute, red, painful joints. Pseudogout, why is it called pseudogout? Well, gout was discovered earlier, and they kept looking into the joints and they kept finding uric acid until one time they found something that wasn't uric acid. And then they were like, well, it's like gout, but it's not really gout, so let's call it pseudogout. So it's a deposition of calcium pyrophosphate instead, not uric acid. Gout is 10 times more common. It's always going to be a leading differential. There are no clinical features that make us suspect pseudogout more commonly than gout, except if they've had pseudogout before. It's suspected basically based on the joint aspirate findings or the urate level, or if you know of a specific calcium or phosphate metabolism issue, which is again very, very niche, unlikely to be present in a patient. So what are the risk factors for gout? And we'll stick to gout for the most of this talk because it's the more relevant one. It's what you'll see most commonly. So what is uric acid and how is it made in your body? It's a breakdown product of purines. Now, purines are chemicals that are used for DNA production, and there are a few ways you can get too much purines effectively. You're either eating too much of purine-rich food like beer, seafood, and cheeses, which is why it's often called the rich white man's disease. You are either breaking down cells too quickly, and a byproduct of that is going to be purine metabolism. So things like tumor lysis syndrome. You can't excrete it effectively. So things like kidney disease, and chronic kidney disease is the most common cause for gout. Or if you've said medications like thiazide diuretics that have been shown to be more commonly linked with gout. Where does it present? It most commonly presents as gouty tophi due to deposition of these uric acid crystals. Common sites include the big toe, the helix of the ear, and extensive surfaces of joints. Some complications that you need to be aware of, firstly, is joint erosion and secondary osteoarthritis. Now, with uric acid deposition into the joint, you're going to lose that smooth boundary of the two bony surfaces that kind of help with that smooth movement. It will eventually lead to joint erosion if it happens many times, and often gout, if you get it once, you're more likely to get another attack later on in life. And that eventually is going to lead to secondary osteoarthritis down the track. You can also end up with joint deformities and chronic tophi over time. Systemically, you can end up with nephrolithiasis with uric acid-based stones and acute kidney injury if the degree of that blockage is quite high, or if you have kind of a post-renal AKI. Now, what are some X-ray changes seen? So you can get periarticular erosions. You can get soft tissue swelling, but quite often the joint space itself tends to be quite normal. Now, if we look at this, what do we mean by periarticular erosion? So this is the articular surface itself. On the sides of it are the peri, or the adjacent to the articular surfaces, and they can often get eroded because of that deposition of crystals in. You can also have soft tissue swelling, and that is entirely the inflammatory process that goes with that deposition and grinding of crystals in as well. And the joint tends to be quite swollen. You can see they've got quite a bit of swelling here, quite a bit of swelling here as well. Always, always, always perform a joint aspirate for these patients, because another main differential you are suspecting is septic arthritis, which is an infection of the joint. It's something that you definitely do not want to miss. What you will see, you can see increased neutrophils and white cells, but most importantly, you will see uric acid crystals, and these are negatively birefringent needle-shaped. And if this was pseudogout, you would see calcium pyrophosphate crystals, which are positive birefringent. What birefringence means is when we look at crystals, we often use two different wavelengths of light, and whether something responds to two or just one of those two wavelengths, I think, is birefringence. So uric acid crystals are needle-shaped and do not exhibit birefringence, and calcium pyrophosphate ones are rhomboid-shaped and they do, or they're positively birefringent. In terms of the treatment, so some basic stuff that you want to always talk about for any disease mechanism is modifying their risk factors. So changes to their diet, making sure they're not having any of that purine-rich food that we talked about. We want to manage their CKD and review their medications. So we don't want them to be on thiazide diuretics. In terms of treating an acute attack, indomethacin, which is an NSAID, or colchicine, is quite effective. You can use intra-articular prednisolone to reduce the levels of inflammation if it is monoarticular. However, obviously, you would not be injecting multiple joints if this was polyarticular gout. Allopurinol is a xanthine oxidase inhibitor, so it prevents purine synthesis. And so it can, by targeting the upstream metabolite, you can actually have reduction in your propensity to have uric acid crystals. But you want to be careful, because in addition to reducing the amount of reducing purine synthesis, what it also does is reduces the threshold for crystal development. Now, what do I mean by threshold for crystal development? In every person, they will have uric acid levels. So uric acid floating around in their bloodstream, which is not in a crystal form. And that's normal. Like, you will have some uric acid because it is part of that normal metabolic pathway. However, with every person, there exists a threshold, and this threshold can be quite subjective. This threshold is basically a point where if your blood uric acid level exceeds a particular threshold, you will start forming crystals. Now, although allopurinol is really good at reducing the level of uric acid, it also reduces the threshold for crystal development. So it can actually predispose, or you can actually end up with an acute gout flare-up or attack after starting them on allopurinol, which is why we often also start them on colchicine for 3 weeks to begin with. You also don't want to use azathioprine because it interacts with xanthine oxidase inhibitor pathway. In most cases today in a hospital, they're often started on allopurinol during their attack, and this is safe to do. If they do not tolerate allopurinol long term, you can also use probenecid. However, just be aware that it can cause kidney stones. Some important points that you need to be aware of with gout and pseudogout. So serum urate levels are a good predictor of gout attacks, but do not look at this during an acute flare-up. So as I said, looking at their urate, we can, as I said, the higher the urate, the higher the likelihood for having a gout attack. However, you need to know that when someone does have an acute flare-up, what's happening is that all that serum urate has now converted into uric acid and is in the joints now, right? Which is why they're having the gout to begin with. So don't look at the serum urate during an acute attack. CKD and thiazide diuretics are your leading causes of gout. You want to start acute therapy with colchicine as soon as possible. You can safely start allopurinol during an acute attack, and do not discontinue allopurinol if they do have an acute flare-up. You also need to know that a high urate level without symptoms is not an indication for starting therapy. It's only when someone has multiple recurrences of gout that you do start them on urate-lowering therapy. But if you just do a urate level and someone has no symptoms, you will not be starting them on allopurinol just to begin with. Why? Because as with any medication, it has a bunch of side effects, and it can also predispose you to then getting gout. So you could end up in a situation where someone just had slightly higher urate levels. Nothing would have come of it anyway. You start them on allopurinol, now they've got gout. And that's all we had. I hope you found that useful. As always, if you have any questions, always feel free to get in touch. More than happy to answer them. And please look after yourself this time of year and look after your friends and loved ones.